class. This is Dr. Ang. I am delivering content for ethical and legal considerations for 3164 today. So I wanted to start by giving a highlight of the information found in your content folder in Harvey. So you'll see we have the learning activities. So read the assigned content. Review the online sources and links, then review the learning objectives, which you find below. Review and print the PowerPoint if you want to do that. I'm going to hit the highlights here with you today. So not as critical that you obviously print those, but please follow along, and that'll be helpful for our information that we're going to share here today. And then review and think about the evidence-based information represented in nursing standards and protocols. Excuse me. So class learning outcomes, previously known as objectives, as mentioned above, discuss nursing considerations related to pain management. So Professor Courtney delivered information, content related to pain, pharmaceutical aspects related to pain, and the patient's perceptions, that aspect. Now we're going to bring in more of the ethical and legal considerations that we need to think about and be mindful of as nurses when we are trying to assess and then treat the pain, proper pain management for our patients and clients. Identify common nursing interventions to meet the physiological, psychological, cultural, spiritual needs of clients that are experiencing pain. And all four of those factors are equally important components for us to be mindful of. Describe and discuss non-pharmacological nursing interventions for a client experiencing pain. So obviously, the pharmacology aspect is critical, but maybe not always our first line of offense. So if there are other things that we can think of to help provide comfort measures that may help reduce the pain that our patients are experiencing, we want to introduce those. And a lot of times those are resources and different things, comfort measures that we can either introduce to that patient, or there may be things, if I go into, let's say, a pediatric room, I'm going to ask, first of all, if appropriate, the patient themselves, if they're of age and capable of expressing that. I'm going to ask them, what do you like to do at home? What helps you relax when you're at home? What can help you calm down if you're stressed or upset or in pain? What are some things we can do? If it's soft music, then we can introduce that. If there are maybe sucking on ice chips, or there's certain things that they enjoy, we want to make sure that we can help with those. Maybe the patient has had surgery and they've been in bed and in the same position for a while, so maybe we can introduce the option of let's go for a walk, let's get up to the chair, let's do some different things, let's get a change of scenery. Do you want to get up and look out the window? Maybe that's calming to you. There are other things, a hot pack, ice pack, different things that we can help that may be things that this patient has used before or may find as comfort measures that we can introduce before or coincide with the current pharmacology aspect of pain. And then identify legal responsibilities of the nurse, individual and family, related to pain management. So what are our roles, each of our roles in this? Identify ethical principles of pain management across the lifespan. So we know when we're treating pain for a newborn or an infant, it's going to vary differently from that of a young adult or middle adult, or then as we get into later adult. And we have discussed before that you'll know, just even from pharmacology, you'll remember things go low and slow for the aging population. So we want to go maybe low doses, and it takes a while for that to metabolize through the body. So we want to make sure that we don't introduce a lot at once, and we give something, and then we got to give it time to actually see if that works. And if it doesn't, we want to make sure that that's completely cleared the body and the system before we introduce something else. That's true for a lot of things, but specifically for pharmacology and pain management. We want to keep that in mind. Then you'll see the readings and resources. I have the readings that you can see on the pages 422 to 425. I've also attached, they're kind of some rough copies. It was a little bit difficult to get those on here, but you can see it nonetheless. And again, read that and skim through it, but I'm going to hit the highlights for you today. Remember my approach, we take a lot of information and I'm going to funnel it down into the need to know information for you. But just note that there are several resources here that you can refer back to regarding pain management, legal and ethical considerations. Then finally, at the bottom of their content folder, you'll see the PowerPoint. So if you don't mind, go ahead and opening that up, and you can reference that as I go throughout my PowerPoint. I have the same PowerPoint, so I'll be just shuffling through these slides, hitting the highlights, letting you know things that you'll want to spend more time on, and then other things that will be important as you progress through the nursing program and then into your nursing profession. There are things that will become more important as you go, and things that you should have on your radar, but aren't necessarily as critical that you master all those concepts and take a deep dive as of at this point in the nursing program. So I'll kind of help you with that to know where to focus your time and energy as far as grabbing this content information. So pain management, let's get started. Ethical and legal considerations for pain management. Objectives here, we've kind of went over these already. Next slide's going to the readings. You'll see in Guido, and you can see best practices there. You can click on this link below and you can get your reading and resources for this content. So pain is an emergency for the person who is experiencing that. This is a very key point, and something that we do know as nurses, but something that when we get busy in our to-do list of things that we need to get done on our shift, it's something that we need to keep at the forefront of our mind, because for the one that's experiencing the pain, it is an emergency situation. If you've ever experienced pain or had a loved one that did, and you push that call light and you're told someone's going to come and they don't come and you're forced to be prolonged, obviously we know that pain will increase, and therefore it's going to be much more challenging to remedy that the longer we let it go. So we need to remember that it is an emergency situation for the one that's experiencing that pain. And it's obviously not for us to judge either how urgent that request is. So making that a top priority is critical, regardless of the urgency of the underlying pathology. So it's not a place for me to say they're not experiencing pain, they just experienced a fall and they should be fine now. Whereas I do think the person on another unit or in another bed or across the hall who had surgery, maybe their pain, I feel, due to the patho of what's going on, I may think that their pain would take priority, when really the pain for each person is equally important and individualized to them and what they're going through. And it's not my place as the healthcare professional. I need to stay just that, professional about it. And when they request pain medication, I need to go in and make that a top priority to assess and deliver equal care, the equality and justice for all, for each of those patients, and making sure that their needs are being met appropriately, and that I'm not deciding where I'm going to ration my care and who deserves my care. Obviously, it's different than prioritization. We need to prioritize our care clearly, but we also need to realize that each person, that pain is very real to them in an emergency situation. For the one that's experiencing it, they want adequate pain relief, and they deserve that. And I believe we must apply the science and art of pain relief through the life as though life depended on it. So this is just a quote that someone has said. We need to pro that, because their healing is dependent on them obtaining proper pain relief. So until we can, that's an emergency situation that we can't tell them the importance of getting up and ambulating and getting your bowels working. We need to make those laps if they're in pain. I mean, that's top priority, is to adequately address that pain management. So quality of life depends on that they can be free of pain or manageable level of pain. So the goal for nurses, healthcare professionals related to pain, the goal is effective pain management. Effective. It doesn't mean that we're going to be having all of our patients or clients pain-free, but effective pain management. Effective pain control and management strategies emphasize shared decision-making, informed and thorough pain assessment, integrated and multi-model and interdisciplinary treatment approaches that balance effective with concerns for safety. So we want to make sure that it's a team approach. So we have the prescriber, the doctor, the nurse practitioner, whoever we have that's prescribing, as well as the nurse that's going to assess the situation. Is this pain medication, if that's what we're doing, is that adequately meeting their goals? Is it helping them to receive effective pain management? And if it's not, our number one role as the nurse is to advocate for that patient. Not to judge, but to advocate for that patient. And if we have an appropriate pain scale, Mr. Jones, what is your pain? Right now, a scale of 1 to 10. If we're doing younger children, you have the face scale. What is your pain now? And then based off that, then we will obviously administer the pain medication and then reassess. If that is not meeting effective pain management, then our top priority is to advocate for that patient and go back to that provider and get something that will. And again, as we mentioned before, we're also going to introduce other things that comfort measures that might also help, that can simultaneously work to provide effective pain management. But key here, top priority is to advocate for that patient. Nurse's top priority, you're going to be the advocate for their pain management. If you call the PA, because that's who you're supposed to call, and you don't get a call back, you go to the attending. You climb until you get adequate and effective pain management for your patient, knowing that that is an emergency to that person that's experiencing it, and they deserve that. The patient's right to pain relief and healthcare team's obligation to provide that relief are basis of the ethical principles of autonomy, beneficence, and non-maleficence. So the key here, the patient's right to pain relief, that patient has a right. That is the duty owed by the healthcare professional to the patient or client that has came to seek that health care. They have a right to pain relief. And it is our obligation as healthcare professionals, under the legal and ethical considerations of pain management, it is our right and our obligation to provide adequate pain relief and effective pain relief. So we will work nonstop until we get to that point, because that is our obligation. And they are based on the ethical principles of autonomy, beneficence, and non-maleficence. So you can look these up, know the difference between each of these. Autonomy is what? I'll give you a while. These are some that you should have had before, but we'll brush up on these just so we know. But autonomy is the state of existing or acting separately from others. This is autonomy. I have the right to choose for myself. If I'm in pain, I have the right to get adequate pain relief. You don't need to come in and give it to me if I don't want it. It's my choice. And if I request it, and a scale of 1 to 10, I tell you I'm an 8, I have the right that if it's prescribed, that the nurse will make sure that I get that medication. Okay, this is a fine line between now. There obviously is some cases of abuse and addictions. That's in another category. We're talking now just as far as basics of just basic proper pain management. Effective pain management is what we're speaking of now. We'll save for another time to discuss the abuse and neglect of pain medications. That's another thing. But as far as autonomy, I have the right to choose for myself. If I'm in pain, I can either request or I can even, on the other hand, deny pain medication, because it's my right to choose for myself what's best. Beneficence is a concept in ethics that states the researchers should have the welfare of the research participant as a goal. Okay, so I'm going to know that beneficence, I'm going to do good. I'm going to do the best that I can for this patient. So if I have a late stage cancer patient and we have it's a blind factor effect that we'll get into later, where I know technically this is a very strong pain medication and more than the average person would be getting, and there can be some side effects and harmful side effects that can come with this, and generally you would not prescribe this high of a dose. I can argue that the benefits for this patient would outweigh the risks in this situation, maybe in a late stage, for a late stage patient. But under beneficence, I'm doing good as best as I can for this patient in this moment. So other factors may come into play, but in this moment, I'm choosing what I feel from my professional expertise. I'm doing what's best, what's good for my patient. On the other side is non-maleficence, and that means not harming or inflicting harm on someone. So if I'm not going to harm, the beneficence is I'm going to do good. Non-maleficence is I'm not going to harm. And in this case would be, I know my patient is in there in pain, and I know I haven't had a lunch break, and I feel like I'm overworked and underpaid and have every reason to just take care of myself in this moment. I'm not going to harm my patient, and I know leaving them in their room for a prolonged period of time in pain is harming that patient. That is not conducive to meeting their optimal outcomes and their goals by leaving them in pain. And I know that that is, in their mind, an emergency situation for that patient. That pain has got to get controlled before they have to have effective pain management before they can do anything therapeutic on any level. Pain is it has to be under control before they can progress. So if, as a nurse, with this ethical principle, I will make sure that that's a top priority, because I realize leaving them in pain is harming my patient. Okay, next slide. Okay, ANA, American Nurses Association, and according to the ANA, nurses are ethically obligated to take action against the disparities associated with access to pain management. Okay, this can be inside the hospital, a clinic, institution, wherever it is that you work as a nurse, wherever you will work, or it can be outside as well. So just accessing proper health care, proper pain management is so critical. So whichever, you may get in a situation where you work and you think this physician or this, whatever this treatment, they don't prescribe enough pain medication for these people. Because we are obviously limiting and restricting based off of the potential for abuse and neglect of pain medications. So in doing so, the opposite end of that spectrum is we can actually under-medicate, where typically we would have send somebody home on maybe 7 to 10 days worth of pain medication and an extra refill just in case. Now we may be, here's 5 days and call if you need more, which sounds okay. I mean, you're giving them the option, but yet at the same time, we need to think about, do they have access to this? Is this an elderly woman that's going home and doesn't drive? Her kids live out of state. Widow with no spouse, no one that lives in the home. We're sending her home with 5 days of medication and telling her you need to be up and ambulating 3 times a day, is that setting her up for success? And maybe it is, depending on the situation, but we need to look at the big picture. And as nurses, we need to advocate to make sure that there are not any hurdles in the way of proper pain management. Obviously, American Nurses Association sets our, is kind of our golden rule. So go to that website, if you don't mind, and see what they have to say with ethical and legal considerations related to pain management. I want you to kind of see what our role is. I have a lot of information on here that's kind of nice to know information. I'm not going to spend a lot of time reading and delivering you all of that content because you don't need to take that deep of a dive for purposes of this aspect, this class today. But just know, kind of familiarize yourself so that as you go throughout the program and then into your nursing profession, that you know where to go to find out what are our core beliefs and the guidelines that are set for our profession. So ANA Code of Ethics, this is kind of highlights them. Just be familiar with this aspect. So I mentioned on the previous slide, you can take a deep dive into it, but just at least know the key components of a nurse. So our professional responsibility, according to ANA, we have a professional relationship with our patients, and our patients' needs are top priority, and that includes pain management. If pain needs are at the top of their list, that should be at the top of our list, because we know that according to ANA, in our Code of Ethics, our patients' needs are top priority for us. And today we have a highlight on pain, so obviously their pain needs, put that as a top priority for effective pain management. We must advocate for our patients. If our patient is in pain, we need to administer their pain medications as prescribed. Obviously, that's our first line. If that's not obtaining effective pain management, we need to climb up the ladder. We need to go call the next one in order. If we don't get effective pain management based on the response from that provider, then we climb up the ladder until we do. And we don't stop as an advocate, patient advocate, we do not stop until we receive an optimal outcome for that patient. So advocating for a patient is top priority with respect to pain management as well. We're responsible for delegating tasks. If we ask our support staff to go and turn Miss Betty to get relief off of her back, and they don't do it, that falls onto the nurse. We don't come later and say, well, I delegated that off. I mean, if they didn't do it, that's their problem. No, it's not, because we are responsible for that patient. It's great. We have awesome support staff that make our jobs so much easier, and they're a wonderful addition to our team. But ultimately, the responsibility falls onto us as the nurse. So in pain management, helping position changes, someone needs to get up, get moving, they want to take a lap around the hall. That's great if we have someone there that can help us with that, to help our patient, because we know that that will help them in their pain and getting up and moving, changing positions, getting off where they don't develop a bed sore, whatever the case may be. If we delegate, can you take Miss Susie around the hall twice, and then when you come back, instead of laying her back supine flat in her bed, can you set her up in the bedside chair and get her comfortable? She likes to do that at home. She also likes soft music and likes to sit by the window where she can have the sunshine coming in on her face. Can you do that? Support staff says yes, they can. You come back out, by an hour later, Miss Susie's still laying supine in bed and hasn't been moved. That's our responsibility as the patient advocate. Even though we delegated that, it falls on to us. So follow through is so important. We strive for healthy work environment. We want a work environment where our patients are our top priority. We don't sit around the break room gossiping and complaining that Mr. Thomas keeps calling out saying he's in pain and snickering at the fact that we know he's not in pain and all he is doing is drug seeking. That's not our place. So having a positive culture is also an ethical consideration with regard to pain management. We collaborate to meet the overall health needs, support and contribute to the development of social policies. So if there are policies that we can see and trends that are emerging from our healthcare environment, it's good to bring that to the forefront and be that agent of change. When you see something that needs change, be the one that does it. Don't sit back and complain. Get in there and make a difference. When you see things that are transpiring in your units, you know that's across the board, and it could help a lot of people and end up advocating for a greater population of patients by doing that. So take a stand with that. ANA also, on the next slide, nurses have an ethical responsibility to relieve pain and the suffering that it causes. Nurses should provide individual nursing interventions. And again, this is something as simple as bringing in a pain medication. You may have a patient that really doesn't like to take the medication, but you know that they need it. Maybe offering, what can I get you? Can I get you some juice? We have orange or apple. Can I get you some more ice for that water? What would make it better? Would you like to sit up? Do you want to wait till you get into your chair? Or how about we take this now and I'll give this time to kick in, and then we'll come up and we'll do our walk in maybe 30 minutes or so. Does that sound good to you, Miss Linda? You know, see what they think, but offering interventions and choices where they feel that there is some autonomy, that they can speak into it. Pain management modalities should be informed by evidence. This is true. Staying evidence-based practice in all that we do and staying in tap with research is critical. Nurse leadership is necessary for society in appropriately addressing the opioid epidemic. So this is where we would cross over. When we are in a controlled healthcare environment, such as in a hospital, and there are medications that are prescribed, we want to make sure that we offer and administer. So we're assessing pain and we're administering based off of that assessment with that patient. Now, when the patient goes home, that is another story as well. Or if there's a patient that comes in frequently with different requests and always wanting or requesting or needing a opioid in order to meet that, then we put that on the radar, not in a judgmental way, but in a professional way, because we do realize there is an opioid crisis and it's very, very real. And another aspect that we do as nurses is we also want to educate. We want to educate people when they come in, and again, not in a judgmental way, but just letting them know something as simple as, how do you dispose of these opioids once you're home and once you have finished this? Or you're going home with a smaller dose. Do you know how that you're going to access this should you need more? And it's very likely that you might. How would you get that? Do you have small children around? Do you have teenagers at home? Can you make sure that you lock these medications up, or are they in your possession? Just different things that we can do to educate, because we know in the greater society there is an opioid crisis. So doing our part, boots on the ground level education is obviously key. But it is a very, very fine line between, we want to make sure we give proper pain management in sync with being fully well aware that there is an opioid crisis. And we can't judge of who that will affect and who it won't, because it goes across there are no boundaries of who the opioid crisis has affected. So just being aware of both of those, it's our responsibility as a nurse to provide adequate pain management and also be aware and educate and be in tune with the opioid crisis, and then what we can do to help. And a lot of times that education is the first step with that. Also, you can go as far as saying, obviously you've had a major surgery, little Timmy, you've had this major surgery. You're going to go home with an opioid. This is a very strong medication, and it's actually highly addictive. So you want to take it as long as you need, but not any further. And you want to start to taper it off. Sometimes after a major surgery or something acute has happened, and an individual might get used to taking it, and they're almost a little fearful of not taking it. So you kind of take it just to protect yourself when really you may not need it. So just letting them know that as well. Start to taper off, slowly taper off, and then just follow-up appointments are critical. Because if you need additional medications, you're going to have to go through a little bit more rigorous process now. And that's another level that we're doing to help combat the opioid crisis. That's truly an epidemic at this point. So jumping back into autonomy, right to self-determination and consent. So informed consents for our clients and our patients is a perfect example. If you were given a question that says, what is an example of an ethical principle of autonomy? Informed consent would be a good one. That is something that you probably will see on the NCLEX. Informed consent is an example of the ethical principle of autonomy. Right to be treated as an individual, institutional considerations, healthcare provider obligation, believe the patient's report of pain, and include them in the decision making. We've already kind of touched on this, but just because I like my medication crushed up, my pain meds crushed up in applesauce, does not mean that Riley wants hers crushed up in applesauce. So again, here's our choices. Always give options, especially with kids. I love to give options. We can do this now, or we can do this in 15 minutes. Which would you prefer? Do you want to get up and sit in the chair for a while and then take your pain medication? Or would you like to take it now, then get up, and then we can walk the hall? This might help you. It may make the walk around the hall a little bit better, but if you choose to, another option, I'm here for that as well. But giving two options. Do you want apple juice? Do you want orange juice? Do you want to sit up? Do you want to stand up? Just different things. Should we turn the TV on, or would you rather have the radio on? Do you want your blinds up? Do you want them closed? Simple things that really may not be perceived that they have any implications or any bearing on pain whatsoever, actually do. You can studies even show if you're sitting up, you have the TV on, you have the window open, and you create more of a normal atmosphere, then you're not so laying down staring at the ceiling focused on your pain. Obviously case by case situation, but what do you like to do for a pediatric patient? What do you like to do at home? Okay, maybe you can't run out and play soccer, but we can probably find it on TV where you can watch soccer. Is there something that you like to eat specifically? What came up on your tray is some casserole and you're not really into that. Well, maybe ordering down a grilled cheese would sound better and would get them in better spirits to be able to. Let's do that. Then we'll take your pain medicine, and then we'll go for a walk around the hall after that. Does that sound good? Or would you rather play video games for a while, then take your pain medicine? Then I can help you get cleaned up, and then we can walk. Which would you prefer? But giving some sense of normalcy. This is autonomy. What's best for you? And as a nurse, I want what's best for you, and I want you to choose what would be best for you, because I know that's ultimately going to support optimal outcomes for this individual. Again, non-maleficence is not harming. I am not going to, this sounds simple, but it's an underlining ethical principle. I am not going to harm you. Clearly, I'm not going to come up and physically harm you, but I need to know as a nurse, I am harming my patient, not even as much as what I'm not doing, but in a sense of what I know that you need pain medicine, and I'm not making that a priority. I'm in no hurry. I need to get down to Starbucks because they close in 30 minutes, and that's a priority to me. And I know that my patient is in there in pain. And if I don't prioritize that, I am harming my patient. So obviously, I need to either get another nurse to cover that, or I need to delay my Starbucks, and I need to get proper pain management, effective pain management for that patient, because knowing I don't have to go in there. This is not talking about, hopefully we're not to this point, but I don't need to go in there and kick or hit my patient. Like, oh, I'm not going to hit my patient. I'm not going to harm my patient. That's not really the aspect that we're talking about here. I hope that you know not to do that. The part we're talking about is I know they need something and I'm not prioritizing that, or I'm not going back in to reassess to make sure that that pain medication meets their needs, or I know that they have said they didn't sleep last night and they've been in so much pain, they're not able to sleep regardless of, I know that they've been getting pain medication every 6 hours. Okay, well, I either need to bring that to 4 hours, or we need to up the dose, or we need to throw that out and get a new medication in, because we need proper pain management, effective pain management for that patient. So again, advocating, because I am not going to harm my patient by leaving them in pain. Emotional damage. I don't know if you've ever been in the hospital or with a loved one that hasn't gotten proper pain management, but it can be emotionally damaging just as much as physically, as to be in physical pain, but the emotional pain of waiting and wondering and not feeling like this is prioritized is not helpful in the healing process either. And then finally, beneficence. Nurses do good. We do good as nurses, patient advocates, and collaborative members of the healthcare team. We are a critical, pivotal point. We have providers and we have patients, and we are sandwiched in there in a magical spot. So we bridge that gap, and we either make a division or we bridge it, and we make sure that there's good lines of communication, because we're effective member of that collaborative team. A provider is not going to know. They don't have boots on the ground in that patient's room. Okay, so they may not know if we don't if we don't communicate with them. Hey, this is not working. Medication is prescribed every 6 hours, and by 3 or 4 hours, they're calling out and saying their pain from a 1 to 10 is an 8. Like, we've got to do something. And if they say no, that's fine, and we climb the ladder until we get effective pain management for that patient, because as nurses and the ethical underlying principle of beneficence, we do good by that patient. Justice for all. The principle of justice states that all persons should be treated fairly according to them in their situation. So we do not, again, as I mentioned, we do not prioritize. If I have 4 patients and one happens to be getting on my nerves and the family members are, I think, like off color, or it seems inappropriate, or I think that the room smells and I don't like the way that they treat me when I go in there. And so, you know what? I don't know that I'm going to manage their pain to the point. I'm going to take this as, I don't think that they need it. They're always calling out, and who knows, they're probably giving the pain medication to other people when I'm not looking. I think they're probably, and you can create in your mind all sorts of reasons why you don't think that patient needs proper pain management, whereas maybe in the next room you can see someone that you think you maybe relate to a little bit more, and it's easier for you to provide optimal care for that patient. Maybe they remind you of your son or daughter, they remind you of your mom, your grandmother, grandfather, some reason that it's just easier. You just have connected a little bit more with that patient. Regardless, both scenarios, justice for all. They both deserve effective pain management. And as a nurse, it's your ethical and legal responsibility to provide. You're obligated in your professional role to provide effective pain management for both individuals, all your patients. the principle of double effect. I'm just alluded to this a few slides ago, but the ANA Code of Ethics requires that nurses must provide interventions to relieve symptoms in the dying patient, even when the interventions entail substantial risks of hastening death. This is what I was describing, that you may look at a pain prescription and say, this is insanely high. This is not appropriate to give to anyone. I've looked at the weight of this patient. I know everything about this. This is way too high. And then under this, you would know, under the double effect, providing comfort for this patient, even though this can be deemed as a lethal dose. It's way too high out of the normal limits. But this patient, if this is for comfort measures, or this is helping that patient, and it has been prescribed, that you know that sometimes the benefits outweigh the risks associated with a certain intervention. Moral negligence in the context of nurse under medicating, there is, if you know a patient needs a certain level of medication to be comfortable and you don't deliver that, there is a moral obligation for you to deliver an effective level of pain management. And this can be off the charts when we're talking about death and dying. Maybe a hospice situation, it can be off the charts, but you know it's your moral obligation to deliver safe medications. We know the number one reason that nurses are brought into legal situations, why torts are filed that will land you in court, the number one reason is medication errors. So we realize that. This is stepping outside of that just a little bit for us to see that although we know that, we also know that it's our moral right, the context in which we practice, that we need to make sure that we are providing adequate comfort and care for that patient as well. And that looks much different in a hospice situation, in death and dying environment, or in that framework. So monitoring that very carefully. And that would also be in close communication with the provider, that patient's family in that situation. But do know what the principle of a double effect means. What is the most common source of liability for nurses in practice settings? I just mentioned this, and that is medication errors. Okay, double effect is not a medication error. That is our moral responsibility to make sure that our patients are comfortable in certain situations that would be different than your normal, such as hospice, a death and dying patient. Legal standard based on duty to perform. So it is my legal responsibility when I am assigned to you. I'm the nurse, you're the patient. I am assigned to you. Now it is my duty as a licensed professional to provide optimal care to the best of my ability, similar to what any reasonable, prudent nurse would